Welcome to the next in the KDIGO Symptom-Based Complications in Dialysis webinar series. Today's webinar is episode 2, Reducing Burden of Physical Symptoms in Dialysis. Our speakers today are Professor Carol Pollock, Coling Institute, Royal North Shore Hospital, University of Sydney, Australia. Our second speaker is Professor Raj Mehrotra, Division of Nephrology, University of Washington, USA. Please submit your questions and complete this episode's questionnaire via Slido at slido.com/reducing. It is my pleasure to turn the webinar over to Professor Pollock. Go ahead.
I'd like to welcome everyone to this second episode of the symptom-based webinar series. I'm very pleased to be involved in this second episode, along with my colleague and co-presenter, Professor Raj Mehrotra. Our topic that we'll be addressing today is reducing the burden of physical symptoms in dialysis. These are my disclosures, and I'll move right into the presentation. So I think it's really key for us to understand what the patient's perspective is of the burden of dialysis. So I guess what I'll be discussing are what are the patient's symptoms, and can dialysis prescriptions or dialysis modality be adjusted so that these physical symptoms can be ameliorated or modified to make a difference to the patient. Professor Mehrotra will be discussing how to implement both non-pharma and pharma interventions for symptom control. And I think it's just important to recognise from the outset, what if we can't fix the problem? And there are many situations that we can't fix, but I think it's important to acknowledge that patients just feel better by virtue of being heard and their symptoms as being recognised as real. So if we look at the symptom burden in patients on dialysis, there's been many publications about this and increasing over recent times. On average, patients suffer from approximately 11 symptoms that range from fatigue, cramping, nausea, insomnia, aches and pains, and several symptoms related to mood. These symptoms are underreported because I think patients consider that nothing is going to be done about them, so why complain? So they're under-recognised. And patients generally, when they're asked, want more interaction around these symptoms. And when asked, symptom relief is a top priority in their dialysis goals. So because of this, we do need to have an increased focus on both research and therapies of these particular symptoms, but also incorporate the discussion and potential treatments into our routine clinical practice. So this is some work from Jennifer Flythe, who's been a key contributor to the area. And I think it really raises this question as where should we target symptom control in dialysis patients? And maybe we should ask the patients themselves rather than just second guess what their problems are. So she developed focus groups that looked at both physical symptoms and mood symptoms, and then prioritised these symptoms based on their frequency, duration, and their impact, both social impact and financial impact. And then did a survey to a larger number of respondents. And these symptoms were then prioritised by the group as being insomnia, which is an area that Raj will address, fatigue, which is an area both of us will address, and cramping, which I will specifically address, and then a range of different mood symptoms, including depression, anxiety, and frustration. Now, SONG is the standardised outcome in nephrology group that was convened in 2014, and it's based on the OMERACT rheumatology symptom process, as well as the COMET process. And what this does is look at different stakeholder groups and what issues are prioritised to be of critical importance or of significant importance by each stakeholder group. And here it looks like there's 2 stakeholder groups, but in fact, there are the patient stakeholders, there's the clinician stakeholders, and then there can be other stakeholders such as administrators or funders, and their input is also very welcome in the song process. And what they do is they look at these core outcomes that are prioritised to be of critical importance by both or all stakeholder groups. And these should be really issues that are then studied and looked at how we might be able to improve some of these. The outer core is those issues that are prioritised by one or the other of stakeholder groups with some overlap, and then together these form a research agenda going forward. So if we look at the song HD, and there are very different areas of this standardized outcome nephrology processes, focusing on different groups. So for instance, hemodialysis, peritoneal dialysis, which is what we'll be discussing today. But there's also been processes around transplantation, polycystic kidney disease, chronic kidney disease in general, etc. If we look at the core outcomes that were prioritised by all of the patient groups and the clinicians, and I'm unclear as to how many administrators and funders were actually in this group, but the top priorities to be addressed were fatigue, cardiovascular disease, vascular access, and mortality. Now you can see in these outer tiers, you can imagine which stakeholder group had actually prioritised these as being important. So, for instance, perhaps the patient wouldn't be so focused on the parathyroid hormone, but they would be more focused on the sleep and the itch aspects. So I think what I'll focus largely on is the core outcomes. So if we look at fatigue, people's perception of fatigue is quite different. And I'm sure we've all had the experience where people come in and they say, I'm tired, and we think to ourselves, yes, we're all tired. But when fatigue is teased out in patients on hemodialysis, it actually means bodily exhaustion. They're devoid of energy, strength, and motivation, and it limits their ability to participate in all aspects of life. And that includes work, hobbies, family responsibilities, and social commitments. And that tends to erode identity and self-esteem. And I think we have heard about this lack of life participation in the first episode of this series. Now, we recognise that fatigue is multifactorial, and there's lots of factors that can contribute to fatigue. And when we try and aggregate this using a meta-analysis, it's really difficult to compare the perspectives of fatigue based on aspects of dialysis prescription, waiting lists for transplantation, what their overall symptom and comorbidity burdens are. And so a lot of the focus has been on post-dialysis fatigue because that is really observed much more frequently and reported much more frequently in the clinical settings. So we don't really have any high quality evidence for interventions to improve fatigue, but Raj will talk about some cognitive behavioural therapy and depression and stress management, and some of the other exercise programs that can improve overall feelings of well-being, and that of itself translates into improved perception of fatigue. There are factors that we can improve by virtue of pharmacotherapy, such as anemia correction and iron depletion. And there is some evidence, and I've referenced these on the slide, that frequent and longer nocturnal dialysis has been associated with improvement in post-dialysis and more global measures of fatigue. Now, cardiovascular disease, we recognise as being a very high comorbid condition in our patients. And we recognise that the risk is higher if the baseline troponin levels are higher. It's obviously multifactorial, and it includes fluid overload, hypertension, uremic cardiomyopathy, there's alteration in the calcium phosphate PTH status, anemia, dyslipidemia, an accumulation of gut microbiota-derived uremic toxins, which may or may not be removed by the dialytic procedure. So what our aims are to try and reduce this cardiovascular burden are to manage hypertension and avoid intradialytic hypotension, and limit structural changes in the heart, reduce arrhythmias, avoid myocardial stunning, which we know leads to myocardial fibrosis and heart failure, and limit vascular calcification, which we know is associated with vascular events. So there are factors that we do modify in the dialytic procedure that are able to impact positively on cardiovascular disease. So we need to be thinking about, is the conventional 3 times per week optimal for people with cardiovascular disease, or should they have more frequent, shorter or longer slow dialysis? Now, for some people, peritoneal dialysis is a better option because of cardiac instability, and often HDF is an option, particularly with online fluid generation, with the opportunity to have cool dialysis. Slow ultrafiltration and isolated ultrafiltration is much more stable hemodynamically. And there's also opportunities to profile ultrafiltration as well as sodium profiling to make more stable, blood pressure. And I'll go through that in a little bit more detail. I think the last EDTA-ERA meeting had several presentations on dialysate magnesium concentration, both to improve vascular calcification, so a higher dialysate magnesium concentration up to 0.75 millimolar or 1 millimolar from our conventional 0.5, and that reduces vascular calcification and reduces arrhythmias. I think we need to avoid alkalosis because we know that there's more likely to be calcium phosphate deposition in an alkalotic environment. And we need to consider the benefits of a higher versus a lower calcium dialysis concentration. We know that a higher dialysis calcium tends to be a more stable and improve myocardial contractility. But we know also that increases the positive calcium mass balance, which then can exacerbate vascular calcification. So I think if we're going to be using a higher dialysis calcium concentration, we need to be very careful not to be using calcium-containing phosphate binders. There's also some evidence that lowering the calcium in regional citrate or when we use regional citrate anticoagulation, that's also able to reduce the calcium transfer to reduce vascular calcification. We recognise now, particularly that we have the use of potassium binders, that the use of low potassium dialysate is associated with unstable cardiac arrhythmias. So I think if we can avoid a K of 1, then most clinicians would do that. And I think if heart failure is exacerbated by large blood flow through the AV access, then that needs to be looked at, and there may be a requirement for banding or revision of the AV fistula blood flow so that there isn't high output cardiac failure. And then there's also dialysate cooling, which I briefly mentioned in terms of online HDF, but that does also create better myocardial stability. So if we look at the issue of daily dialysis or longer overnight nocturnal dialysis, this was a relatively small study looking at conventional 3 times per week hemodialysis in this first bar. And this is in-centre short dialysis, home nocturnal dialysis, and then short frequent home dialysis. And you can see here the ultrafiltration volume is vastly reduced in the home, nocturnal and short dialysis modalities. The ultrafiltration rate is also decreased, which is intuitive. But when we look at the number of regional wall motion abnormalities, it actually correlates very strongly with the ultrafiltration rate. And in the two methods where there is reduced ultrafiltration volume and rates, then there's also a reduction in these regional wall motion abnormalities that indicate ischemia during the dialytic session. So this is some data looking at cooling and resultant cardiac and neuroprotection. And I realise it's quite small to see, but on this heart side of things here, these are all markers of cardiac function, left ventricular ejection fraction, left ventricular mass, etc. And you can see all of these parameters are benefited with a cooler dialysate versus a standard dialysate. When we look at neuroprotection, the same occurs in that there is the abnormalities in cerebral blood flow that are improved with cool dialysate. And interestingly, I think Raj published in CJSON just this week that in pediatric patients that they tend to have more cardiac ischemia during dialysis, but they're less likely to have neural ischemia, which I think is a good thing. I don't really understand the mechanisms, but they probably auto-regulate somewhat better than what us older people auto-regulate. So there is also, in addition, remote ischemic preconditioning and more frequent dialysis to try and prevent this hypoxia and target organ damage. And this here is a patient who's cycling while they're on dialysis, and this has not caught on, in a holistic or a pervasive fashion. And certainly I think it's something that has been demonstrated to be quite effective across a number of different parameters. And this looks at exercise to protect against this stunning in the heart, these regional wall motion abnormalities. So this is the control period. You can see here, and there's an increased estimate of these regional wall motion abnormalities in the control that is reduced significantly if a patient has exercised before dialysis and during the dialytic procedure. Now, blood pressure is also a significant issue in the cardiovascular management for our patients, and it is difficult. So dialysis patients were quoted as saying, I hated dialysis, I couldn't get my treatment right. One day it was cramping, the next day it was more medicine for blood pressure. So this is really just reflecting the hypotension and then the hypertension. It's very common, and it's sometimes quite difficult to address. So if we look at intradialytic hypotension, there's several different definitions, but the one that I've used here is any symptomatic decrease in systolic blood pressure or a nadir intradialytic systolic blood pressure of less than 90 millimeters of mercury that requires attention. So I think that we realise that the commonest cause of intradialytic hypotension is an ultrafiltration rate that exceeds the corresponding plasma refilling rate long enough to reduce the plasma volume to a critical level. So there's a few things that we can do. I think people omit pre-dialysis blood pressure medications, and then some of the modifications on dialysis that we do include both sodium profiling and ultrafiltration profiling. And to do that, that often requires the biofeedback with relative blood volume monitoring that occurs in our more modern machines. And what happens there, this feedback regulates the the sodium and the ultrafiltration profile, such that during the first half of the dialysis session, the sodium profiling prevents a sharp fall in plasma osmolality and therefore increases the plasma refilling rate. And then the excess fluid is drained from the intracellular compartment and is removed by means of a higher ultrafiltration rate, thereby achieving most of the weight loss required without a very significant change in intravascular volume that precipitates hypotension. The higher dialysis calcium, I've mentioned, can improve myocardial contractility, and the lower dialysate temperature can reduce the hypoxia to the heart and therefore also maintain both cardiac but also vascular stability. Isolated UF is also important, as that can sometimes be more stable. And I think we also need to be looking at online HDF, which has more stable membranes as well, more stable ultrafiltration, as well as the use of more biocompatible membranes. Now, obviously, there's other pharma approaches to hypotension that we also need to be looking at. So then if we look at intradialytic hypertension, this is regarded as a rise of blood pressure of about 10 millimeters of mercury from the pre to post dialysis to the hypertensive range in the majority of dialysis. So we can reduce dry weight. We should be reducing dietary sodium. And I think that we do recognise that some of these people actually do need a very significant assessment of their dry weight, because it could be a renin-dependent hypertension, in which case pharmacological intervention may be required. But in general, when we reduce the dry weight, we can probe the dry weight with progressive reduction in weight over successive dialyses. We can decrease the dialysate sodium, and I think it's really important that people recognise that they need to absolutely decrease their sodium intake. And I think sometimes the priming of the dialysis lines, actually with a high sodium sodium concentration, actually adds a significant amount of sodium to the patient and increases their thirst. So long dialysis is better for improved ultrafiltration, and it's important that we use non-dialysable blood pressure medications. And particularly our junior staff might not recognise what those non-dialysable blood pressure medications are. Also, I think there's other aspects to hypertension, such as sleep apnea, that Raj will also discuss. Some of these other symptoms that people complain of, such as nausea, vomiting, headache, cramps, and itch, are improved by long and slow dialysis, in particular itch and cramps and headache. But interesting, nausea and vomiting isn't something that is necessarily improved by longer and slower dialysis. With itch, we can modify the calcium in the dialysate, and we recognise that phosphate is better removed with hemodialysis than with hemodiafiltration. But these don't seem to make a significant impact on itch. And now I think we're very grateful that we do have pharmacological treatment that, again, Raj will speak on. If we just look at the short daily hemodialysis compared to conventional dialysis, then there are benefits. It does increase our estimates of dialysis adequacy if we think about adequacy in terms of KT on V, and I think we're moving away from adequacy as determined by KT on V and have a much more global view of this. But there is a general impression of improved health and patient satisfaction using quality of life measures that are modified for the patient with kidney disease. When conventional dialysis is resumed after 6 months of short daily hemodialysis, then the perception of general health actually falls below their baseline, and there's no difference in cognitive function, mental health, or emotional or social functioning with this short daily hemodialysis. So we can't expect it to fix everything. So the other issue that people raised was access. And I think we need to be aware that one size doesn't fit all in terms of access. So it's different depending on what people's goals of therapy are. And on occasions, if people have a likelihood of a short-term survival, then it is perfectly reasonable to be thinking about a central venous access, or is it best to put in a graft? Optimally, we would like an AV fistula, and the site of the AV fistula is important, and that's based on where the best vessels are to create that AV fistula. But access is so important for patients as part of their overall life plan and goals of plan that it should really be individualised for the patient. Access monitoring is something that is, I think, done more uniformly to try and predict a problem before a problem becomes a need for revision of access. And the monitoring is usually done by specialised dialysis access nurses, and then they bring it to the attention of either the nephrologist or the vascular surgeon or radiologist, with the aim to preemptively address any impending problem. I've included here buttonhole cannulation and rope laddering because that does seem to prolong AV fistula life, can only be used in AV fistulas and only in people who self-cannulate with blunt needles. So it's not for everyone, but it does seem to prevent aneurysmal development and reduces pain during cannulation, which is also something that patients complain of. So I think if people can do it, it's something that's worth considering. Now, just to briefly speak on peritoneal dialysis, there is there's an overlapping set of core outcomes that are relevant to the patient and to the physicians. But importantly, this issue of life participation that I discussed earlier that was relevant to fatigue. So I think it depends on how people express what the problem is. In the PD population, they're very keen to maintain life participation, which they see the modality as being, conducive to that. Interestingly, here we look at the issues that are of concern, and almost in all cases, they're more of a concern to the health professionals than they are to the patients. So, the worry of health professionals is greater compared to the patients, which I found interesting. And the exception being blood pressure, where patients were more concerned than doctors were. So we've obviously educated our patients fairly well about the issues related to blood pressure. So in terms of reflecting on these domains, we really need to look at the individual patient priorities because they're not the same for everybody, and what might improve life participation for one individual may not be identical to the next individual. But when we're looking at how to implement some of these changes, there are some areas where it is pervasive across backgrounds and cultures, and we should be looking at factors to try and improve the prolongation of PD, because people see that being on PD does improve life participation compared to being on hemodialysis. So that really means we need to be trying to prevent PD infection and prevent membrane failure. And that is an hour-long talk in itself. So I think that, there are things that we need to focus on, and I've listed these in the slide here, but I think most importantly, we need to be focusing on unit expertise in peritoneal dialysis, and that means both physicians being trained in the use of PD, how PD should be modified with time, with the progressive loss of residual renal function, and to train patients so that they can optimize their success in the PD process. So I'll finish there, and I'll hand over to Raj, who will now look at implementing the non-dialytic therapies and interventions for symptom control. So thanks for your attention.
Thanks, Carol. What I'm going to do in the next 20 minutes is to introduce to you some approaches that does not involve changing the dialysis prescription in managing physical symptoms that are experienced with kidney failure. These are my disclosures. I want to start by reminding ourselves that the contemporary practice of nephrology is that we should start dialysis or kidney replacement therapy upon the appearance of symptoms. I've just put up here the KDIGO clinical practice guidelines that makes that recommendation. It is not a very strong guideline. It's graded at 2B, but that is the contemporary clinical practice around the world, is that we wait for appearance of symptoms for initiation of dialysis. The implication of that is that when we start dialysis, symptoms will get better. It is true that some symptoms get better, but there are many symptoms that do not get better. There are very few longitudinal studies of symptom burden in people that start dialysis. This is a relatively small study, but it makes an important point. It makes the point that there are absolutely some symptoms that do get better. I've highlighted here the shortness of breath, but then there are other symptoms also, such as anorexia or uremic encephalopathy. They all get better, but then there are others that don't, such as muscle soreness, chest pain, cramps, dry skin, and others. And in fact, if you look at cross-sectional studies of people that have advanced chronic kidney disease and compare them to those that are on dialysis, the symptom burden is similar. If we are not using dialysis then to manage symptoms, we have two broad approaches. We can either have drug therapy, prescribe them a pill, or there is a behavioral therapy, and sometimes we can use both. Each one of them comes with its own problems. With regards to drug therapy, the biggest problem is the pill burden. On the right, you see this frequency histogram that tells you the average number of pills a person on dialysis is asked to take in a single day. There's a study we did in 3 different centers in the United States. On average, a person is asked to take 19 pills in a day. And if you're going to add 1 pill for every symptom, we're going to exacerbate this pill burden. And then in people with kidney failure, medications can have side effects, and those adverse events add further to the symptom burden. So never say never, but the point is be careful when thinking of a drug to be prescribed for managing symptoms. Behavioral therapy, of course, does not have those disadvantages, but usually behavioral therapy requires once-a-week therapy sessions, and that makes scheduling very challenging for people that are undergoing dialysis. In people that do in-center dialysis, they have to come in for treatments 3 times a week. For people that are doing dialysis at home, it's 5 to 7 days a week of treatments. And then there are other medical appointments on top of that. And I think for behavioral therapy to be more widely available, we need more innovative solutions. either in leveraging existing personnel or hiring new personnel, and possibly telehealth. With that as a background, I want to talk about 3 illustrative symptoms. I don't want this to be a laundry list. I want to use them to see how we can leverage drug therapy or behavioral intervention for treating symptoms that are commonly experienced by people on dialysis. And I'm going to focus on insomnia, pain, and pleuritis. Let's start with insomnia, and let's start with understanding what is insomnia disorder. What is important here is it's the definition, it's the formal definition that is up there, that it is patient dissatisfaction with sleep quality or duration, along with other nighttime and daytime symptoms that are present 3 or more nights per week and last for more than 3 months. So I could break this down into 4 parts. The first is that the patient has to be dissatisfied with the quality of sleep or duration. So there are people that may sleep for 4 hours. If they're not dissatisfied with 4 hours of sleep, they don't have insomnia. So it needs to be an impression communicated by the patient that they're dissatisfied. It simply is not a problem with sleep quality or duration at night. They also have daytime symptoms. They have to be frequent enough. They have to be present at least 3 or more nights in a week. And they have to be present for at least 3 months. What are the nighttime symptoms for insomnia? It could be difficulty falling asleep at bedtime. It could be frequent or prolonged awakenings, or people may wake up early in the morning, like wake up at 3 in the morning, 4 in the morning. They were not ready to wake up, but they wake up. But nighttime insomnia symptoms are not enough for them to have a diagnosis of insomnia. They have to have daytime symptoms, because if they're dissatisfied with the quality of sleep, it's because they have fatigue and reduced energy in the day. They could have impaired attention, concentration, or memory. It can lead to mood disturbances and also result in difficulty functioning in academic or occupational settings. There is a large menu of treatments that are potentially available for treating insomnia. And I'm not going to go through this laundry list that is divided into behavioral, pharmacologic, dialysis-related, treatment of comorbidity, or others that are important. I'm not going to do that. But what I want to point out is that it is behavioral treatment that is recommended as first-line treatment for insomnia in the general population. This is from the clinical practice guidelines from the American College of Physicians for the general population. And the first recommendation is that all adult patients should receive cognitive behavioral therapy for insomnia, or CBTI, as the initial treatment for chronic insomnia disorder. And this is a strong grade with a moderate quality evidence, but this is the treatment for which there is the strongest evidence for treatment of insomnia, and it is for behavioral therapy in the form of CBTI. Up until I got interested in this, my default in treating insomnia was to prescribe a pill. But actually, the evidence for the safety and efficacy of sedatives and hypnotics for treating insomnia is not very strong. And so the American College of Physicians recommends that if CBTI does not work, only if CBTI does not work, should you then go on to a shared decision-making approach to add pharmacological therapy, but only for the short term. So this is what's in the general population. What about for people on dialysis? Before I go on, I apologize. Let's just talk about what is cognitive behavioral therapy for insomnia. And I don't expect a nephrologist to be prescribing cognitive behavioral therapy for insomnia, but it is important for us to understand what the different components of that are. The first thing is sleep restriction. Essentially, don't try to be in bed for so long, try to be up and about so that you feel tired, so that there is an increase in sleep drive. The second component is stimulus control, so that you decrease arousal in sleep environment. And what that means is, hey, you shouldn't have like a bright screen of a TV or your phone or your iPad that you're tracking. And particularly if you're seeing a movie, it shouldn't be something that is like arousing you in terms of your emotions. And the goal is to control the stimulus to promote the concept that once you are in bed, it is to sleep. The cognitive part of the cognitive therapy is to restructure maladaptive beliefs. There is, again, relaxation therapy is a part of that to decrease the physical and psychological arousal, improve sleep hygiene, to reduce behaviors that interfere with sleep drive or increase arousal, such as, example, taking coffee too late in the night, for example, would be that. There are 3 clinical trials that have tested the efficacy of cognitive behavioral therapy in people that have problems with sleep in those that are undergoing dialysis. And overall, as you can see, this diamond that is on to the right demonstrates that treatment with cognitive behavioral therapy for insomnia in people on dialysis is effective in improving the global Pittsburgh Sleep Quality Index. There is also improvement in sleep latency. That means the time that it takes from the time that you go to bed to when you fall asleep, sleep disturbance, and sleep medication use. There is no improvement in some of these other parameters, such as subjective sleep quality, sleep duration, habitual sleep efficiency, and daytime function. So I would not say that the evidence for efficacy of CBTI is overwhelming, but it is sufficient for it to be consistent with what's recommended in the general population for CBTI to be the first-line treatment for insomnia in people on dialysis. So it seemingly works, but with behavioral therapy, the challenge is to make it available to patients. And so what I do, and what I suggest you do, is to start with sleep hygiene. Avoid stimulants close to bedtime. No daytime napping. That's particularly important for people on dialysis, that they shouldn't be nap. Like, it is common for a lot of people when they're undergoing hemodialysis for them to nap. And then they've napped for 3 hours in the day, and then they're not able to sleep at night, is to kind of go away from that. If it's not effective, if sleep hygiene alone is not effective, and the patient is tech savvy, you may try self-directed internet-based CBTI. And there are courses such as that are available for people to do that themselves. If they're not tech savvy, I would propose you try leveraging the social worker in the dialysis unit or to identify a therapist for CBTI. And I do think it is important to test telehealth solutions to increase access to treatment. Just want to introduce this clinical trial that we have been doing here in Seattle and in Albuquerque that is near completion, where we are identifying people with insomnia, and then we are randomly assigning them to CBTI that is given by telehealth or trazodone or placebo for 6 weeks. And then we will have a relative efficacy of these 3 approaches. We anticipate the results to be available early next year. So for insomnia, behavioral therapy is recommended as first-line therapy. What about pain? Patients experience both chronic pain and acute pain without regard to dialysis modality. So it's not a hemo thing or a PD thing. A lot of our people experience a lot of pain. Chronic pain is often neuropathic, such as from diabetic neuropathy, or musculoskeletal, such as cramping or secondary hyperpara. Superimposed on this background of chronic pain are these episodes of acute pain that may happen because of falls and fractures. Carol talked about the vascular access issues, and there's pain that is from the needle stick that happens 3 times in a week. In PD, there's dialysate installation that causes abdominal distension and discomfort. And then add to that other vascular access complications, such as needle infiltration or vascular steal. And then there's the issue of headaches. There are widely variable estimates for prevalence of pain, but the floor of those estimates is that at least 20 to 30% of people have significant pain, and chances are that that proportion is higher frequently. So what are options for treating pain? Just like for other symptoms, there is the drug therapy or the behavioral therapy. The challenge is that there is no easy way forward in treating pain. There is acetaminophen, which is a good analgesic, but it is effective up until a point. With regards to non-steroidals, the risk is with regards to both the safety on the GI tract, as well as in people with residual kidney function. COX-2 inhibitors, concerns about residual kidney function. Tricyclic antidepressants can cause confusion and disorientation. And similarly with SSRIs and gabapentin and pregabalin are other side effects. Unfortunately, what is often used then to treat chronic pain is opioids. And I'll talk a little bit more about the risk with using opioids in this patient population. In how difficult drug therapy is for managing pain, behavioral therapy has a lot of potential, but there is, and what the purpose of behavioral therapy is to help people cope with pain, to reduce interference by pain in day-to-day living. So it's like pain coping skills treatment, rather than it being an analgesic. Now, there are many problems with opioids, and this is just illustrative. That's data from the United States showing that at least from 2006 through 2010, there was a larger and larger proportion of people that were being prescribed with opioids for 90 or more days. And if you look at any opioid prescription, that's almost 2/3 of people on dialysis would get a prescription of opioid in any given year. Now, the proportion of people that get long-term opioids in the United States has gone down somewhat. In people that have long-term opioid use, as you can see, just if you focus on any one column, if you focus on death, for example, and kind of go down, if in people that have short-term opioid use have a higher risk for death compared to those that don't. And then if you look at the different dose levels, MME stands for morphine milligram equivalent, the higher the dose of opioids that is prescribed, higher is the risk for death. Higher is the risk for discontinuing dialysis. Higher is the risk for hospitalization. By that same token, there is, in addition to those side effects of death, withdrawal from dialysis, and hospitalization, there are other adverse events. For example, hospitalization for altered mental status is 67 times higher in people that are taking more than 60 milligrams of morphine MME per day than those that are not taking any. Falls are 45% more common. Fractures are 65% more common. So opioids are associated with adverse outcomes, a very wide range of adverse outcomes. The question that has never been formally tested, at least in people on dialysis, but it has been tested in the general population, is we have all of these risks, but do they even work? Do they even relieve the pain that people are getting the opioids for? And the short answer to that is not very much. So that the chronic pain has a lot of psychosomatic components, and opioids are not the drug to treat. Opioids are very good for nociceptive pain. You get surgery, you have that incision that cut all these nerves, and the nerves are inflamed, and you want that that pain relief, the opioids work. But in chronic pain, opioids are not very effective. They're not very effective, and they come with this plethora of side effects. So there are alternatives needed for pain, and that brings in, there's another much larger clinical trial that has just been started in the United States, the HOPE-HD trial, where people, over 600 people, 640 people, are being randomized to either pain coping skills training or usual care for 24 weeks. I'm not going to talk about this section on buprenorphine, but essentially to point out to you that there is the first and the largest multi-center clinical trial for reducing pain is ongoing, funded by the NIH in the United States, and we would have some answers with regards to behavioral therapy in the next 3 years. So to summarize here, with chronic pain, the drug therapy is poorly effective, generally unsafe. Behavioral therapy has potential and is being tested in clinical trials. You could say that I'm kind of leaving you vague with vague recommendations and hanging. I'm saying don't use drugs, but we don't know if behavioral therapy works. I think my suggestion would be is to see what the options available to you are, is that be very careful in using drugs. Use if you have to, see whether or not you can get cognitive behavioral therapy available to patients to reduce pain interference. Wrapping it up, moving on to pruritus. Pruritus is common in people with dialysis. These are data from the DOP study with over 6,000 patients from 17 countries, over 250 medical directors from around the world. And in this study, the summary evidence, this is externally valid, that 18% of patients were very much or extremely bothered by itchy skin. What's not surprising is that 69% of medical directors actually underestimated the prevalence of pruritus in their facility. And among patients that were nearly always bothered by itching, a significant minority had no treatment prescribed for them. So I think it's fair to say that the lives of many of our patients could be improved by increased awareness of CKD-associated pruritus. So what are our options for treating pruritus? I don't list here topical treatments. I personally try topical treatments first, like emollients or things such as that. But there are generally broadly either, again, drug therapy or behavioral therapy. And the drug therapies that's up until recently that have been tested was gabapentin and pregabalin. But more recently, we have Diphallicufflin. I'm proud of myself to pronounce that. Or then there's behavioral therapy for which there's not much evidence. I'll just leave you with this, I think, a very important clinical trial, which was one of the pivotal trials reviewed by the FDA for the use of Diphallicufflin for pruritus. It's a peripherally restricted drug, as in it does not cross the blood-brain barrier effectively. So it acts on the peripheral nervous system, and it is an agonist for the kappa opioid receptors on the peripheral neurons and immune cells. So in this clinical trial, 378 patients with moderate or severe pruritus were randomly assigned to Diphallicufflin or placebo, and the drug was given intravenously 3 times a week for 12 weeks. And if I can draw your attention to the upper left panel, which is the primary outcome measure, that was at least a 3-point reduction in this itch score. And as you can see, 31% of people in placebo, 52% of people that got Diphallicufflin had an improvement in itching. And then there are these other panels show other ways of looking at the data, demonstrating similar greater efficacy of the active drug Diphallicufflin relative to placebo in reducing itching. This is the first drug that has been specifically approved for reducing symptoms in people with kidney failure on dialysis. And this is a cut and paste from the package insert from the FDA that it's called Karsuva. It's a kappa opioid receptor agonist that is indicated for the treatment of moderate to severe pruritus associated with CKD in adults undergoing hemodialysis. The first and the only. So for pruritus, it's the only symptom for which there's an FDA-approved drug for treatment. So I want to pause right now and be happy to take any comments or questions people may have.
Thank you very much. At this time, we'll move ahead to our questions and answer portion of the webinar. Go ahead.
Okay, well, thanks very much, Raj. That was a really enlightening presentation about the non-dialytic therapies of patient symptoms. We do have a couple of questions, and I might direct the first one to you. You talked a bit about pharmacotherapy and behavioural therapy, or the combination of the two. So maybe you could just be a little bit more specific about what patient characteristics or clinical scenarios would guide you to one or either or both of those therapies.
Thanks, Carol. It's not an easy question to answer. And again, I'm just maybe not give a definitive answer in that regard. It in part depends upon the symptom. So for some symptoms, behavioral therapy is really the first line therapy and should always be used, such as for insomnia. For others, it is not that clear cut. I mean, we're not talking about emotional symptoms, for example. I mean, but an illustrative example is depression. You know, whether you have antidepressants or psychotherapy, they're similarly effective for mild to moderate depression. So unless there is a compelling reason to choose one or the other, it then is a matter of shared decision-making between the patient and the physician, as well as what is available to them for treatment. So sometimes the decisions would be made for them because, for example, behavioral interventions would not be available, or an expensive drug is not covered by insurance, for example. And so those could be the circumstances where that decision-making would be. So I think oftentimes it is that shared decision-making and what is available will determine what treatment people get. And then, you know, I talked about insomnia, where behavioral therapy is the first line. Pleuritis is the opposite, where actually we have an FDA-approved drug that works. And in somebody who's being really bothered by pleuritis, the drug would be the way to go. Let me ask you the next question. Is there epidemiological evidence to support the association between the level of physical symptoms and adverse outcomes, whether it's all-cause mortality, cardiovascular mortality, or something related?
Yes. Look, I think that there is epidemiological and also, well, I guess more observational evidence that there is an association between symptoms and mortality. I guess the majority of the association is really with depression. And I guess that's not surprising because depression is then associated with a decrease in the health-related quality of life, related with a decrease in activity and an increase in mortality, not only due to withdrawal of dialysis, but including withdrawal from dialysis. The DOPS actually have also looked at the association of physical activity and self-reported activity and quality of life, depression and mortality. And they also found that people who exercised more, participated in exercise programs, had better quality of life, less depression, and improved mortality. Now, that's quite, confounded data, because obviously if people can exercise and can participate in activity, then probably their general health is better and therefore their mortality is lower. But when they reported that, which I think was in your journal again, in C. Jason, in I think up to the 2011 time period for DOPS, they looked at the units that had more formal exercise programs, and they did seem to have a better outcome and less symptomatology reported. So I think, again, that comment that I made about trying to more formalise exercise in dialysis units, there is at least some observational evidence for that. There's also evidence that fatigue is associated with an increase in mortality. And I think when we look at the palliative care outcome scales that have been developed, particularly for renal, then some of the aspects of that include the issues that we've been talking about, patient symptom burden, then they are predictive of mortality. And so they're used by our colleagues to look at the delivery of supportive care structures. So I think that, that the associative data is really strong. The interventional data to improve mortality is much less strong. And I think that's where we need to be focusing.
I agree.
Look, I might ask you then the next question. I mean, I thought you gave some great tips about quality of sleep. In fact, I think I might implement some of them myself. But what are the metrics for assessing improvement in the quality of sleep based on those interventions?
Right. I mean, I think for day-to-day clinical practice, just having a conversation with the patient, at least in some depth, would provide information that will be very meaningful. So there are the 3 questions to ask for the nighttime symptoms. And it is like, how long does it take for you to go to bed at night? Go to sleep once you're in bed? Do you wake up in the middle of the night and then not be able to go back to sleep? Or are you awake early in the morning and then earlier than you'd like to be? And then there are the daytime symptoms of fatigue, inability to concentrate, how it affects their functioning. So one could do that just in taking a clinical history. Alternatively, there are standardized tools to assess insomnia. The one that directly measures insomnia is Insomnia Severity Index. Unfortunately, that's not what's been used in all of the studies that have been published in nephrology literature. Often it is the Pittsburgh Sleep Quality Index. But be as it may, those would be the 2 instruments if you want to formally assess them in day-to-day clinical practice. But I just think that just a good history in listening to the patient would provide the most meaningful information.
Mm-hmm. Yeah. Yes. And I think sometimes people make the mistake of thinking fatigue is all related to sleep when there are other aspects that need to be addressed to help with fatigue, such as depression.
Let me ask you, as I'm thinking about this, one of the questions that often comes up is that nephrologists are not very aware of people's symptoms. And it's easy to kind of turn around as though patients don't tell us. And there are sometimes genuine reasons why people may be concerned about talking something that's very sensitive, such as sexual dysfunction, or there are still mental health conditions around which there's a lot of stigma, such as depression. How do you facilitate that conversation with people to encourage them to talk about it?
Yes, no, I think it's extremely important, because I think some of our colleagues think that they can look at the dialysis prescription and the dialysis information, look at the biochemistry and hematology, and don't necessarily need to speak that much to the patient, but just make modifications via the dialysis unit. And I think that really isn't holistic care that should be delivered to the patient. So I think we are in a privileged position as nephrologists that we do get to know our patients quite well over time. And I think it may even be easier for us who have known a person for many years to raise some of these issues, and people hopefully feel comfortable enough that they can say that they're thinking that they're depressed, or we can raise it with them, or that we think that maybe their personal relationships aren't as good as what they could be. And raising issues like sexual function or sexual dysfunction more likely, probably isn't as challenging for us when we've known somebody for many years. I think that a really key issue is that this shouldn't be done in the dialysis environment, because you're standing there talking to somebody within earshot of another patient and staff, and patients are much less likely to share personal issues, and particularly because a lot of these things they feel they should be able to cope with, or should be able to manage themselves, particularly cognitive dysfunction or emotional areas of emotional support, and also, sexual dysfunction. And, there are things that we can definitely do to support each of those that if we don't proactively raise, they may not know that we can do things to support them. So I think it does need a proactive discussion, and not just a questionnaire, because the questionnaire depends what you do with the questionnaire. And I think a lot of people just put that in the drawer rather than using it as a stimulus for the conversation. Sometimes I think people are very familiar with their dialysis nurse, and so they may be more likely to confide in the dialysis nurse than the dialysis doctor, because they may perceive the doctor as too busy or too, other bigger things on their mind than the fact that they've, got pain or that they're not sleeping. And so I think it is often a multidisciplinary discussion. The social worker often finds out these things that are, distressing. I think one of the issues that I find difficult is in people from a non-English speaking background who either have an interpreter or have a family member acting as the interpreter, because, some of these sensitive things people don't like to discuss more broadly. So I find those challenging. And also there are cultural issues that people from whatever background they're from don't like to talk about. And so as a female doctor, there are some cultures that males won't want to talk to me about sexual dysfunction. And so then if that is an issue that sometimes the partner would report to me, then I might need to look at another colleague, potentially raising it in a way that is going to be sensitive to that particular person. But I don't know. I think it's very dependent on the individual relationship that you have with the patient. And I don't think that there's a one-size-fits-all.
Well, thank you.
So we might wrap up then. I started. Do you want to finish, Raj?
Well, it's been a pleasure to be here with you. This has been very enlightening for me as well. And we look forward to seeing you in the next webinar for KDIGO.
Thank you.
On behalf of our audience, I want to thank both of our speakers for their great presentations as well as their deft handling of the questions and answers. This webinar was supported by an unrestricted educational grant from Vifor Pharma. At this time, we will end the webinar, and you may now disconnect.